doctor moves to drug B. If drug B is ineffective, it moves to drug C, and so on and so forth. Now, this is a very consuming blood pressure lowering treatment strategy because it takes weeks or even months to decide whether a drug is effective or not. But the greatest limitation of this strategy is that monotherapy in general is not particularly effective in controlling an elevated blood pressure. And this is an example from an old study on isolated systolic hypertension, randomized study. You can see that at the end of the treatment titration, well, only a minority of the patients had a sizable blood pressure reduction and blood pressure control, regardless which monotherapy was used. 1 out of 4 patients, 1 out of 5 patients. On the contrary, if we add the second drug to the first drug, the response of the patient, as far as blood pressure is concerned, is enormously greater. This is a very large meta-analysis, and it is a very famous study, old study, showing what happens if you add a second drug, the green histograms, or continue with the first drug by increasing the dose. And I think it's visible very clearly that if you add a second drug, no matter which the first drug is, the chance of achieving blood pressure control is 4 to 5 times greater. And if you add a third drug to a 2-drug regimen, there is a further sizable blood pressure reduction. This is an example. Patients on 2 drugs having a blood pressure reduction by 2 drugs, the blue histograms. If a third drug is added, the orange histogram, you can see that the magnitude of the blood pressure reduction is clearly much, much greater. This is the reason why guidelines since now more than 20 years or 25 years, all recommend combination treatment as the most important treatment strategy for controlling blood pressure in hypertension. And this is exemplified by what has been a very popular antihypertensive treatment strategy, the so-called treatment step care approach. We start with 1 drug. If 1 drug is not effective, we add a second drug and then a third drug and maybe even a 4th drug. Now, there is nothing wrong from the point of view of the logics as far as the step care approach is concerned. And indeed, it is true that most patients need more than 1 drug in order to have blood pressure control. This is one example from a study which was published a number of years ago, and it refers to the number of drugs used in several well-known trials. And you can see in average number of drugs in these trials was always greater than 2 drugs and sometimes even 3 drugs. And evidence has been obtained that if we look at the effect of combination treatment on cardiovascular events, then there is the specific evidence that combining drugs is protective. And this comes from a meta-analysis of randomized trials. You can see here what happens in studies using 2 drugs versus 1 drug, or using 3 drugs versus 2 drugs, more complex treatment versus less complex treatment. And you can see that most of the hypertension-related cardiovascular events were reduced by combination treatment. So we do have evidence that combination treatment, when specifically addressed, is protective against hypertension-related cardiovascular events. What is the problem then if there is a general agreement about the effectiveness and about the protective effect of combination treatment in hypertension? The problem is that still today, in many countries, monotherapy remains the most common type of treatment. You have an example here in different countries, different studies, and in all these countries, about 2/3 of the patients remain on combination treatment compared to 1/3 in monotherapy. And this is regarded to be the reason why blood pressure control around the world, control of an elevated blood pressure is so limited compared to the potential of having a much more expanded blood pressure control. This was the reason why already in 2018, the guidelines of the European Society of Cardiology and the European Society of Hypertension decided to move to a different treatment strategy, abandoning the step care approach. That is, to recommend to start treatment with with two drugs rather than one drug, increasing the dose of the combination component, and then finally going to triple therapy in absence of blood pressure control, thereby shortening fundamentally, substantially, the titration phase. Now, in the last 5 years, important evidence has been obtained in favor of this new treatment strategy, that is, starting with two drugs rather than one drug. And the first evidence has been that if we start with two drugs, of course, we shorten the titration phase, which is a very delicate phase for the patients, because, of course, the patient doesn't know whether blood pressure is going to be controlled or not, and can have fear that the disease is not manageable. In this study, you can see that patients starting with two drugs rather than starting with one drug, during the titration phase, there was a progressive increase in the number of patients with blood pressure control. But the titration phase was completed 20% less time in patients starting treatment with two drugs rather than one drug. And the importance of initiating treatment with two drugs was also visible in several studies by the number of patients who, at the end of the titration phase or even earlier, had blood pressure control. This is a study, the TALENT study, which was published a number of years ago, and it was a combination of telmisartan with the calcium channel blocker. And you can see here the percentage of patients achieving control office blood pressure, but also control of ambulatory blood pressure after 8 weeks of treatment. So at an earlier phase of the titration to treatment. And please notice that those starting treatment with telmisartan plus a calcium channel blocker had a significantly greater rate of ambulatory and office blood pressure control compared to those starting treatment with one drug only, that is the combination components given as monotherapy. Now, don't think that pressure control is clinically not significant. It is significant because there is evidence from trials that in patients at high risk, such as, for example, those of the VALUE study, earlier blood pressure control was associated with patient's protection. Here you have data from the so-called immediate responders, those in which blood pressure control was achieved within 1 month, compared to those in which control was achieved later, after 1 month. And you can see that those with earlier blood pressure control had a reduced risk of cardiovascular events. But the evidence collected in the last few years have gone also to some important practical aspects of antihypertensive treatment. We know that a big problem for the treatment of hypertension is low adherence to the treatment schedule and high treatment inertia. That is, inability to go beyond current treatment if blood pressure is not controlled. And these two factors represent two important factors against use of combination treatment. Now, you have here the data from a database, very large database. We are analyzing in Milan, the place where I live, as more than 10 million people, and we have access to the analysis of these data. And what we did here was very simply to see what happened as far as treatment prescription was concerned in patients starting treatment with one drug in the following 3 years. And you can see that those starting treatment with one drug slowly increased use of combination treatment, but after 3 years, only 1/3 was on combination treatment. Of course, the problem can be bypassed by starting treatment with 2 drugs. You can see that those starting treatment with 2 drugs, well, maintain more or less 80% of the patients in which the 2-drug treatment schedule continued to be used. Then there is a very interesting finding again from the Lombardy database, that is that starting treatment with 2 drugs is associated with a reduced rate and risk of treatment discontinuation. You can see here data in which the reference value is those starting treatment with 1 drug versus those starting treatment with 2 drugs. And please notice that over the years, the risk of discontinuing treatment was markedly less in those starting treatment with 2 drugs. And we know that those discontinuing treatment, well, they have a big problem because this is accompanied by a very marked rebound increase in the risk of cardiovascular events. This is a very nice study from the NHANES database in the United States. That is a comparison of the chance of having blood pressure control 1 year after treatment initiation. Compared to initiation of monotherapy, those initiating treatment with 2 drugs, 1 year later, they had a very clear and significant increase in the chance of reaching blood pressure control. And data on cardiovascular events, not from randomized trials, but from observational and in some cases population studies. That is a very interesting study. It compares those starting treatment with 1 drug with those starting treatment with 2 drugs, the white line. In those starting treatment with 2 drugs, there was an earlier increase in the number of patients achieving blood pressure control, and this was accompanied by reduction in the incidence and risk of cardiovascular events. And this is also data in this direction from the Lombardy database. Those starting treatment with 2 drugs and continuing with 2 drugs, very large numbers, of course, in these databases, as you can see, had a 26% reduction in the risk of cardiovascular events. And this, relates to the same issue, and it shows that those starting treatment with 2 drugs, well, they had a reduction in the incidence of cardiovascular events compared to those starting treatment with 1 drug. The other issue I would like to mention before closing is that 1 single pill combination is associated with an improved adherence to treatment and a further cardiovascular protection. Here we compare starting treatment with single pill combination of 2 drugs, and you can see that compared to those in which use the same drugs but given separately, there was a significant increase in those being highly adherent to treatment and significant reduction in those having poor adherence to treatment. That is less than 25% of the follow-up time covered by prescription. And this was associated with effects on cardiovascular events. The greater was adherence to treatment, the lower was the risk of cardiovascular events. Now, the last point I would like to mention and have to mention is which combinations. And this is the algorithm of the European Society of Hypertension guidelines. And you can see that several combination treatment can be used, but the advised combination in most patients is a blocker of the renin-angiotensin system together with a calcium channel blocker or a diuretic. Any other combination, however, can be used, as shown by the figure showing that several drugs can be used in combination with one another. And indeed, there is evidence from randomized trials that many combinations do have evidence that the risk of cardiovascular events is reduced. So my message is, please try to use combination treatment as often as possible, because this is the best chance we have to improve the currently poor rate of blood pressure control, as shown by a study done in different continents. And first author was a famous Indian scientist, Professor Yusuf. As you can see, out of the large number of patients with hypertension, well, only a minor fraction of the patients had blood pressure below the values we consider to indicate blood pressure control. Thank you very much for your attention.
Thank you, Professor Mancia. We are very much enlightened with your lecture. So from your lecture, what you can conclude that either dual or triple single pill combination is the drug of choice for the management of hypertension, for the effective management of hypertension. Anyway, what Professor Mancia said about his international experience, now we have got another speaker, Professor Saumitra Roy, from Woodlands Hospital and from the Municipal Heart Hospital. He is one of the senior most cardiologist, academic cardiologist, interventional cardiologist at Kolkata, and he is very much well known all over India. He is very much rather involved in the Cardiological Society of India. So today he is going to speak on the national experience or Indian experience of combination therapy in the management of hypertension. And after his session, we are going to have question and answer session, and we will take the different questions from the audience and also from the other people, and we will try to answer the question. Professor Saumitra Roy.
Thank you, Professor Kaur. Thank you, Professor Mancia, for a very crispy presentation and putting the perspective of the subject tonight. My job is a bit simple, just to keep the Indian perspective a bit and to focus on a particular combination instead of all the combinations that you have discussed. But before I go into hypertension, there is a kind of social obligation. This is our colleague, a cardiac surgeon who died at the age of 39 while going to the operation table, or OT theater, only 2 weeks ago. And basic cause was not hypertension, actually sleep deprivation. So that was found out to be the finding in his, and so there is a healthy heart initiative which is coming from America and Europe, where with the essential lifestyle changes, we are talking about sleep also nowadays. 6 to 8 hours of good quality sleep is essential for life. And there is some studies very interesting showing that if you sleep below 6 hours a day, your chance of mortality is 23% more. And if you sleep more than 8 hours a day, your chance of mortality is 40% more. So better to undersleep than oversleep. And for siesta, Professor Mancia will understand and appreciate it very much from Italy. Siesta more than 1 hour is very harmful, but siesta from 30 minutes to 1 hour is very beneficial to health. So with this perspective, our company has also launched very good initiatives and patient awareness, and we should all stick to that to spread the awareness of healthy life, including sleep and stress. But coming to my presentation, the prevalence of hypertension in adults in India, the last statistic says around 30%. 30% in adult population, be it rural or urban, be it male or female. As simple as that. And more scary data is that 22% of adolescent and school children between the age of 12 and 16 are hypertensive. 22% of Indian school children, again, not from urban area, these are from semi-urban areas. So that's a very, very scary data from India. And as I said, 20% of young adults suffer from hypertension. And of course, 50% of patients have uncontrolled blood pressure, and Professor Mancia has explained it very, very nicely. And another interesting thing is that majority of cardiovascular events occur with blood pressure below 140/90. which is the so-called standard, and even today's standard by European guidelines. 2,500 adults hypertension follow-up for 7 to 8 years, and it has been shown that total events when happened, only 37% had uncontrolled blood pressure and 63% had controlled blood pressure. Control means below 140/90. That is the impetus or incentive for the ACC to bring down the threshold to 130/80. Of course, both ESC and ACC say the target is 130/80, but threshold for treatment should also be 130/80. And how to achieve that? All authorities say start with 2 drugs. Europeans said fixed dose combination. Americans saying you can give them freely in different combination. 1 RAS blockade plus 1 CCB or a diuretic. Here comes a very old study published many years ago, 22 years ago, that is accomplished study where you combine amlodipine with benazepril versus benazepril and hydrochlorothiazide. So RAS blockade with CCB, RAS blockade with diuretic. Both are very first-line therapies by today's standard. But what you see here, that by accomplished trial, that benazepril with amlodipine scored over benazepril with diuretic in all the counts, starting from MI to stroke to heart failure. So that is a very interesting observation. And if you see the effect of thiazide and calcium blocker in combination with ACE inhibitor is more prevalent with the normal body weight. If it is a heavy person, then perhaps they are equal. But for the lean body or BMI below 30, CCB is far better than diuretic. Maybe in obese patient, diuretic is as good as CCB. So that was the thing. An accomplished trial showed also the kidney disease progression also favors calcium channel blocker compared to the diuretic arm. So how we can bring this accomplished trial result after 22 years, and whether we can substitute amlodipine by a modern calcium blocker with cilnidipine and the ACE inhibitor benazepril by an ARB, tell me certain. So that remains the question whether we achieve the same benefit as accomplished. Cilnidipine, you know, is a dual-acting dihydropyridine calcium blocker equal in efficacy to amlodipine, but which does not cause edema and actually can reduce heart rate. Do you take this statement on face? It is equal in efficacy in amlodipine. Many doctors have got the doubt that it is not as good as amlodipine in terms of efficacy. Actually, we did a trial from India with Dr. Venkatram. I was part of the trial. It is called TELCOM trial, which was published in American Journal of Cardiology 3 years ago. And it is the first time in the world where it was shown whether 130/80 target can be achieved with telmisartan amlodipine vis-a-vis telmisartan cilnidipine combination. First time in the world it was published and done. And it was mild to moderate hypertensive patient who are not controlled with one therapy. That is 130/80 and above pressure with monotherapy. So you are giving them into. And we also knew that brachial pressure is not everything. Central pressure and central parameters are very important. So Dr. Venkatram got a very fantastic instrument where we could do the central pressure, aortic augmentation pressure, aortic augmentation index, and all the central parameters non-invisibly. And what we found, it was telmisartan with 5 milligram amlodipine versus telmisartan with 10 milligram cilnidipine. Look here, not 20 milligram, not 40 milligram, 10 milligram cilnidipine against 5 milligram amlodipine with telmisartan 40 remaining same. And what we found, exactly equal blood pressure control in the both arms. What we found, 24 hours ABPM control at the end of two months, exactly same. What we found, central aortic blood pressure level, exactly same. Central aortic augmentation pressure, exactly same. Pulse wave velocity during the follow-up, exactly same. Excellent tolerability also. Again, here we funnily showed that amlodipine and cilnidipine had got same edema. So at least we prove here that cilnidipine 10 milligram is equivalent to amlodipine 5 milligram in potency and its side effect, and they can equally reduce the blood pressure to the target of below 130/80 in majority of Indian patients with mild to moderate hypertension. So why choose cilnidipine? If amlodipine has cilnidipine have got the same effect and side effect, why cilnidipine? Now there are 4 points or 3 points in favor of cilnidipine. Number one, cilnidipine increases plasma angiotensin 1:7 to angiotensin 2 ratio in patient on this combination, a finding likely to be cardiovascular benefit. This is one reason you should give cilnidipine rather than amlodipine. Second point, CCB-ARB treatment significantly reduce of urinary albumin-creatinine ratio, whereas amlodipine increases urinary albumin-creatinine ratio. And we now today knows that urinary albumin-creatinine ratio is very important in cardiovascular outcome and overall prognosis. Third point, cilnidipine but not amlodipine prevents increase in angiotensin 1 and angiotensin 2. It prevents. So we don't want angiotensin 1 or 2. ARB actually tries to increase angiotensin 1 and 2. This is the difference between ACE inhibitor and ARB. So ARB makes the angiotensin 1 build up in the body. So once you give ARB, you should give something which reduces angiotensin 1 production and angiotensin 2 level. And that is not amlodipine, but cilnidipine. And also there is some metabolic effects also in terms of obesity and in terms of HOMA and insulin resistance and so on. So these are the positive points of cilnidipine over amlodipine when you prove that they are same in efficacy and maybe same in side effects. Maybe, but we all know that amlodipine has got more peripheral edema, but somehow in our study we could not show that. So in summary, friends, ACCOMPLISH showed the powerful heart, stroke and kidney protection of a calcium blocker RAS inhibitor combination. To transpose that ACE inhibitor and amlodipine combination after 2 decades into present perspective, cilnidipine telmisartan combination, how does it fare? And we could prove even in Indian setting that it is a fantastic combination to achieve the target organ in majority of Indian patients with mild to moderate hypertension, not only the brachial pressure, but also the central blood pressure parameters, with equivalent side effect, but with certain advantages in terms of cilnidipine. And sometimes we say that cilnidipine 10 is actually not sufficient for amlodipine 5. Cilnidipine 20 is good as equivalent to amlodipine 5. But in our study, lo and behold, even cilnidipine 10 was as good as amlodipine 5. But your experience may vary. I admit that. I many times use myself cilnidipine 20, 30 or even 40. But at least there is no side effect even on a higher dose. The attributes of the combination of cilnidipine and an ARB, 2 newer drugs which advantage over the original ACCOMPLISH agent, provide superior cardiovascular and kidney protection for patients. And I stop over here and I give back to Professor Kaur.
Thanks, Professor Saumitra Roy, for your lucid talks on the management of hypertension by combination therapy of ARB or AC inhibitors plus calcium channel blockers. Now, I have got some queries about that ACCOMPLISH trial, because it was what Dr. Rai has said, that it was a very old trial. I think it was published in 2010 in New England Journal of Medicine. And at that time, among the AC inhibitors, remember that the molecule which was used there, that is benazepril. But at that time, ramipril also was very much available there in the market. But in spite of ramipril, rather benazepril was used, which is not a common drug. I mean, at that time also, now also it has gone into almost oblivion. True. So why it was used during that time? And amlodipine, okay, fine, amlodipine is a very strong antihypertensive drug, but it has got some side effects like pedal edema, tachycardia. But now, at this moment, what you said, that a combination of telmisartan and cilnidipine has got a very better effect than those. I think we should not consider this ACCOMPLISH trial because of that molecule of benazepril. Amlodipine is all right. But benazepril has, it has not been used in any other trial rather. So what is your comment about that? This beauty or plus points or minus points of this ACCOMPLISH trial? Yes, anything? Yeah.
Actually, it was a contemporary at that time. Benazepril was used at that time quite a lot. Though there was not much of event reduction trial with benazepril in future happened. which happened with perindopril or ramipril or enalapril, etc. But for hypertension effect, it was good. It represented ACE inhibitor. It was a standard ACE inhibitor. So now the question is whether ACE inhibitor can be replaced with ARB. That is the more relevant question rather than among the group of ACE inhibitors. So I think at the moment for uncomplicated hypertension, ARB is a drug of choice because of better tolerance. Long-acting ARBs are available. Most of the ACE inhibitors are not long-acting, excepting perindopril, because even ramipril is not long-acting, but telmisartan and olmesartan are long-acting. Side effect profile is very good, and there are enough data to show their efficacy and safety in uncomplicated cases. Of course, if there is heart failure, if there is ischemia going on, we prefer ACE inhibitor as a RAS blockade representative rather than an ARB. But without those, for a low-hanging fruit like a common day-to-day hypertension, ARB is a more comfortable agent to use, but it has to be a long-acting ARB. Dr. Mancia, Professor Mancia, your comments?
I think I agree. No, my comment is, in general, what is important is really to consider giving patients a combination of drugs, a combination of 2 drugs in the majority of patients, and in a fraction of the patients, in combination of 3 drugs. I think all combinations do have evidence of effectiveness in a way, but I agree with you that blockers of the renin-angiotensin 2 blockers, well, they do have an advantage, and this advantage is, of course, the tolerability profile. And we consider tolerability as a very important factor for favoring adherence to treatment. And so this is certainly not a minor advantage.
Any question from the outside? Any question coming from the other centers?
Yeah. Show me that question and answers list. There are some question and answer list is there. And another thing, in accomplished trial, most of the patients, they were having uncontrolled systolic hypertension. Yes. So the spectrum was totally different. So that's why you cannot you cannot extrapolate that accomplished trial to our present situation.
But again, having said so, if you see JNC 1 to 3 concentrated only on diastolic blood pressure. They didn't think systolic was important. But since then, after the MRC trial and then JNC 4-5 concentrated both on systolic and diastolic. But then JNC 6-7 said only systolic. And even the biggest trial nowadays, like SPRINT trial, they only took the systolic. So diastolic is how much relevant in today's world is still a grain of salt we take, with a pinch of salt, we take the diastolic blood pressure unless it is very high. Though all the guidelines and guideliners say that either more than 140 or more than 90, you have to take the same approach. But isolated diastolic hypertension is how much important, still there is some doubt. So I think still our focus will be systolic blood pressure control, unless it is a young person with isolated diastolic hypertension, etc. Professor Mancia, what is your idea about isolated diastolic hypertension, its relevance today, how important it is?
I think it's, of course, it's extremely important. You think that isolated systolic hypertension, isolated systolic we're talking.
Isolated diastolic.
Diastolic, sorry. Of course. Well, isolated diastolic hypertension is a Cinderella, and has been a Cinderella of the guidelines because, it has not even been mentioned in previous guidelines. Now guidelines do mention this. The guidelines of the European Society of Hypertension do mention this. But for sure, we know that it characterizes mainly middle-aged or younger people. And it is not uncommon, but is not, of course, as common as isolated systolic hypertension in the elderly. And third, we do not have unquestionable evidence. We know that diastolic blood pressure is a risk factor, like systolic blood pressure. But as far as isolated diastolic hypertension, randomized clinical trials specifically devoted to this question are not available. We recommend, of course, in younger people who have an increase in diastolic blood pressure to try to lower diastolic blood pressure based on epidemiology mainly.
Absolutely. So diastolic blood pressure isolated, we took it in perspective depending on other risk factors. But still today, it is not as important as systolic hypertension or isolated systolic hypertension. Maybe it is, but there is no evidence so far. That is the stand.
In fact, above, there has been a paper, very interesting paper, showing that in younger people, diastolic blood pressure is epidemiologically more important, but then it progressively goes down and the importance of systolic blood pressure increases, and more or less the turning point is 55 years, if I remember correctly. And systolic blood pressure is by far much more important than diastolic in the elderly people. And indeed, a low diastolic blood pressure, very low diastolic blood pressure in elderly people is a marker of large artery stiffness, and it is associated with a particularly marked increase in cardiovascular risk.
Absolutely. And our more day-to-day problem is more while controlling systolic BP, we have got very low diastolic BP in elderly people. We have got 150 by 60 millimeter, and we don't know what to do, whether to increase the medicine.
These people are at high risk because, absolutely, I mean, they have a stiff arteries. In addition, there is the problem that lowering systolic blood pressure is inevitably associated with lowering of diastolic blood pressure. Yeah. You cannot be selective in lowering systolic blood pressure. So when you have a patient with 60 millimeter mercury diastolic blood pressure, there is the possibility that lowering diastolic blood pressure is associated with the J-curve phenomenon.
Yeah, and subepicardial ischemia and coronary disease may precipitate.
Now, I will ask one question to Professor Mancia. Now, about the second generation, or you can call third generation calcium channel blockers like cilnidipine, this is much more effective than diuretics in elderly people who are having systolic hypertension. You will prefer third generation calcium channel blockers or diuretics?
The problem of effectiveness on blood pressure of different drugs, of course, you can find anything you like in different studies. But if you look at big numbers and big meta-analysis, I mean, what comes out is that taking the general hypertensive population, more or less, these drugs have a similar effectiveness. This doesn't mean that in individual people, one drug can be more effective than another, but this has to be resolved by a try and see treatment strategy.
Yeah. Any question coming from other centers or from the floor? Yes, doctor.
A person who has got labile hypertension, mind it, it's labile hypertension, with the same work throughout the day or the same lifestyle. Today it is systolic is 140. Tomorrow it is 160. Day after it is 170, and fourth day it is 130. What to do? How to control with the cilnidipine? She is taking same dose of cilnidipine, or you will daily change it?
So, Professor Mancia, the question is that sometimes
yes, can you? Yes,
very labile hypertension, very much fluctuating. So, how to adjust doses in these cases of antihypertensive medicine? Because without any rhyme or reason.
In an individual with labile hypertension?
Yes, sir.
This is the question?
Yeah.
Well, first of all, I mean, labile hypertension is not used too much now today. I mean, I think it's hypertension within the term you more frequently see in the literature. Well, this is a difficult question in a way, because you need to try to characterize what is the average blood pressure level by increasing the number of blood pressure readings and prolonging the observation period. In the end, you may have a better idea what is the blood pressure regimen, more or less, but it still remains the problem of the lability of blood pressure. So it's one of those issues, not too rare in medicine, in which guidelines cannot help the single physician very much. I mean, the single physician has to try to get the best information possible by increasing the number of blood pressure readings.
Yeah, Dr. Chand, actually, in my experience, many of these patients have got overt or subclinical anxiety, neurosis, depression syndrome. And their blood pressure is dependent on the mood, which is not lifestyle. And they also sometimes don't recognize that their mood is fluctuating. So here, we have seen very good effect by the yoga concentration technique, yoga pranayam techniques, and focusing technique. And beta blockers may help in such cases to stabilize the mood a bit, because these are basically sympathetically driven hypertension. They're usually not volume or RAS dependent. They're usually sympathetically dependent. So some kind of sympathetic blockage may help in many of your patients. You can try and see.
So you don't give you won't advise the patient to daily titrate the dose.
No, daily titration never works, sir. Because any blood pressure medicine has got any medicine has need 5 half-lives to attain a stable dose. So if you change today of cilnidipine, its effect will be after 3 days. By that time, the pressure may be automatically low if the patient is more relaxed, and there will be hypotensive effect. So we should not change blood pressure medicine on this unless there is a very high blood pressure, 200 by 130, or very low blood pressure when the patient is falling or postural giddiness. Then we have to either increase or decrease medicine. But within a range, we should keep an observation rather than trying to change the dose.
Can I add something which
Yes,
I forgot?
Sir, please.
And this is a situation in which measuring out of office blood pressure is important. That is, if you measure 24-hour blood pressure and you find variability and calculate the 24-hour mean, this is important information, because 24-hour mean, regardless how variable is blood pressure during the 24 hours, is associated with a pretty good predictive ability as far as cardiovascular risk is concerned.
This is one question from Coimbatore. Professor Mancia, do you need routine measurement of central aortic pressure for assessing cardiovascular benefits? Central aortic pressure.
Yes, good question. Central blood pressure is a very interesting physiological concept, because this is the blood pressure which is seen by the vital organs. Vital organs do not see radial artery pressure. They see aortic pressure, they see carotid pressure, they see pressure in the renal artery, so in the central arteries. So this is a very good argument, a very good topic for research. I think it's not ready to be used in clinical practice because, first of all, would make the life of physician and the cost much greater. Secondly, it has a predictive value, but it's still not clear whether the predictive value of central blood pressure is better than the predictive value of traditional classical blood pressure. So in my opinion, leave it still to research, but not recommend the central blood pressure for practical use. Not yet, at least.
Actually, it should still be reserved for the trial situations to see the efficacy and comparative efficacy of different drugs. And once we are sure that they are doing equally good, we promote those drugs, but don't do the same test on everybody. It's still experimental basis and it's not practicable, and it's usually invasive. So what we used in our study was a very, very fantastic gadget which does it non-invasively, but it's very rarely available, I can tell you. Not available in India at least. It was an imported machine and we have to give it back. So it is not that practicable.
Among the ARBs, is there any choice how to make a choice about telmisartan or olmesartan, or there is no such extra points or extra advantages?
So
Because
Professor
now,
Mancia, among the ARB, how do you choose the agent?
I think, first of all, the duration of action, I think it's important. And there are several ARBs which cover clearly the 24 hours, some not. For example, losartan has been the first and has good evidence of protection, but has a shorter duration of action than the following ARBs drugs. So this is, to me, the main factor to look at. As far as the other factors are concerned, I think not all ARBs have evidence from large randomized clinical trials, but in general, the feeling is that more or less they have the same clinical profile.
thank you.
Yeah. So one is the duration of action, and second is both telmisartan and olmesartan are equally long acting. But then you see who has got more backup of evidence of good
Exactly.
effect.
This is what
So
I meant
telmisartan
was
has
as
got
far
more
as
than olmesartan.
Telmisartan has got more.
evidence is concerned. Yes.
My last question from my side, Professor Mancia, do you think this combination of ARB and calcium channel blockers has got some pleiotropic effects in addition to the controlling the blood pressure?
Very good question, but very difficult question. Because this has been looked at for many, many years without coming out clearly with a clear answer. I mean, the strongest evidence is that most of the protective effect of antihypertensive treatment is due to blood pressure lowering per se, regardless how it is obtained. If you compare different drugs in large meta-analysis, you see that for a similar reduction in blood pressure, the differences between drugs are very small or non-existing between all 5 major drugs. But this is not the case in some specific conditions. For example, chronic kidney disease, there is no question that blockers of the renin-angiotensin system do have evidence of a greater protection. But in the general hypertensive population, my bias is that what is really important is controlling blood pressure. Pleiotropic effects cannot be excluded, of course, but they seem to me to cover a small portion of the benefit at the best.
Yeah, actually, Professor Kaur, pleiotropy is a very, very difficult word. I mean, say RAS blockade is good for kidney disease. Calcium blocker is good for angina. So these are not pleiotropic effect, isn't it? I mean, they are effects, other effects.
No, these are other effects. They are effects in different patients, which is different.
Yeah,
yes,
exactly.
Yeah, I agree.
Exactly.
Yeah.
So pleiotropic effect generally means we don't understand what it is doing, but it's doing some good. So that is pleiotropic.
Well, for example, greater effect on arterial distensibility, endothelial protection,
everything
things
goes to
like this. That
endothelium.
is pathophysiological markers, and we can easily understand why it is difficult to give a value to these markers, because it can be that they are better on some markers, but what is the relevance of these markers to the overall patient's protection?
Exactly. So one question came from Dr. Srikant Govalkar. Is dose response in a given patient predictable? Combination may bring down blood pressure to very low level. So should you start with a combination?
Yeah, of course. This is a relevant question clinically, and the guidelines of the European Society of Hypertension, they do recommend initial combination treatment in the vast majority, but not in all patients. Okay, so patients above 80 years of age, frail patients, well, in this case, cautionary reasons are important, though, so we should start with one drug. Or, for example, patients with a slight elevation in blood pressure, for example, very close to 140 millimeter mercury, or high-risk patients with a blood pressure between 130 and 139 millimeter mercury, who are candidate for treatments. Then it takes a few millimeter mercury to go below 130 millimeter mercury, which is the target blood pressure, and one drug can do this. So there are some subgroups in which initial monotherapy is still recommended. But in the majority of hypertensive patients, we think that combination treatment initially is important.
The last question to Professor Mancia. Do you think there is increased major cardiovascular events if you bring down the blood pressure to 140/90 or below?
This is a debated issue. I think that, and there are the different, I think that in patients above 79 years of age, the first goal is to go below 140/90 millimeter mercury, because at this level there is already a clear-cut protection. Okay, the fraction of the protection achieved by going below 140 millimeter mercury is remarkable. But then if patients tolerate further reduction, we should try to go below 130 millimeter mercury. In patients with isolated systolic hypertension, old age, or those above 80 years of age, according to the European guidelines, we should be a bit more careful. That is, below 140/90 millimeter mercury if treatment is tolerated, but not below 130 because there is no evidence of further benefit, first of all, and secondly, there is the problem of serious side effects, including, of course, orthostatic hypotension.
Many thanks to Professor Mancia for taking the trouble to do this discussion with us in spite of the fact that you are at vacation. Thank you. Thank you.
Thank you.
Okay. Now, micro people.
I will also do one vote of thanks, sir.
Yes.
So, on behalf of Micro Labs, I just want to thank Dr. Mancia for accepting this request and addressing the community of Indian doctors. And especially I want to thank Dr. Saumitra Roy for accepting, sir, many last-minute suggestions you included, sir. You gave us the space to communicate to and included, and thank you very much, sir, for that space. And Dr. A.K. Kar, I am always nervous to speak to senior doctors, and still, yesterday you asked me to smile, and today the program went off very well. So I want to thank Dr. A.K. Kar for ensuring that that energy is there in the...
No, you are not nervous.
So thank you very much, sir, for excellent moderation, sir. It was a bit difficult managing the technology part of it also and the question answer session also, but you helped us in supporting this very well. So I want to thank you also, sir. And I want to thank all the doctors who are present here, who has given us this time today. We don't take it lightly. It means a lot to us. Thank you very much for your time. And there are 2,250 doctors listening to this online. And I want to thank all the doctors who are online with us from all the corners of India. There were many questions which we couldn't pass it on to you. We will come to you, sir, with a printed questionnaire, and we'll try to answer those. We'll try to take those questions, Dr. Mancia, also in future. And there are few people here who did a lot of work in the background. My team members, my area managers, my boy, Priyatosh. So I want to thank Mrudul, ASM, my RSM, and Jayanta, sir, who is our sales head. Thank you all. Thank you very much. Thank you.
And have a nice weekend, Professor Mancia. Enjoy the rest of your holiday.
Thank you very much. Thank you very much.
Recording stopped.